Bem-vindos a mais um LungTalks. Hoje dedicamos este episódio ao tema fibrose quística na era dos novos moduladores da CFTR. O meu nome é Fernanda Gambôa, sou pneumologista no LS Coimbra e temos connosco o professor Carsten Schwarz, diretor do Centro de Fibrose Quística de Potsdam, na Alemanha, membro da direção da Sociedade Europeia de Fibrose Quística e um dos especialistas europeus com maior experiência nas áreas de infecções respiratórias, infecções fúngicas e cuidados nas pessoas com fibrose quística. Professor Schwarz, welcome to LungTalks.
Hello.
Thank you very much for joining us today and for sharing your expertise with our audience. And to start our conversation, I would like to give your opinion. Over the last few years, we have witnessed a remarkable transformation in CF care with the introduction of highly effective modulators. From your perspective, what has changed the most in the daily clinical management of people with CF?
Yeah, so when we look back, I mean, the first modulators were started already in 2012, so it's 14 years ago. And I think the big change was almost 6 years ago. So 2020, we had the possibility to start with Kaftrio, with ETI. And there was a big change, so patients were really stable. And if you look at the FEV1, it's much, much better than before. So the lung disease is stabilizing. Patients have less infections. And on the other side, they also don't want to come to the clinic anymore that often.
Yes, I said
so
no.
That's really an issue. But there you can see that they are really stabilizing and that they're almost getting a normal life. I think that's maybe the description which is best. Yeah, that they really are close to a normal life and they're thinking about getting children, so family life.
They're getting children,
yeah,
in fact.
They do.
They
do,
yes.
Yeah.
Some of my patients improved 1 liter in FEV1.
Yeah, it's amazing. So it's not only 5%, there are patients really have no cough anymore, they have no sputum anymore. Yeah. So it's really a game changer, and that's what we see and what we get as feedback from the patients.
And in this context, what do you consider the most urgent items to address with this new population as the infections are becoming more rare? What are the challenges that this new population represents?
I think it's very important to know that there are challenges, because I think patients say, no, I'm stable, everything is fine. And also some colleagues are saying that. And I think that's not the truth. So they have not a normal lung function. You still see bronchiectasis on CT scan or MRI. They might have a liver disease. They might still have gastrointestinal pain, for example, or disturbance. And we know also that the patients still have inflammation. So they are really not healed. Therefore, we think besides the modulator therapy, it's still necessary in most of the patients to somehow do a little bit of therapy. So I mean, inhalation therapy, also sport. And they are becoming older, so also we have to do something to stay stable, although we are healthy. I think that's the challenge we have, to really be in touch with the patients and really explain that they still have to do something. And I also think when we are talking about infections, that we sometimes miss infections, because before it was always clear they had a lot of sputum, the sputum was darker, and they really didn't feel well. So we know that's an exacerbation. And right now, it's more sensitive. Maybe a little bit lower lung function, maybe a little bit of sputum. And then I said, no, it's fine. I don't take an antibiotic treatment. And I think there we have to learn, the patient and also the doctors.
And do you think the treatment of infections are different? Are we doctors giving more antibiotics by phone and without seeing patients?
Yeah, we do. We do. And also that's a pity. I mean, for us, for example, only if we see the patient, it will be paid. So all these emails and telephone calls and everything is not paid. So I think it's also then lack of money for CF centers. And also we want to see the patient and not only hear her or his voice. So I think that's a problem. So we lose a little bit the contact, and then suddenly there might be a drop. But also if I don't know, a patient has an infection on Friday and he can't come, we want to have him or her an antibiotic at home so that they can directly start. But there's also a change, for example, in winter we had a lot of viral infections. Yeah, and at the beginning, usually it is a viral infection, and I would say more than 50% having only a viral infection, but the others, they then afterwards still have a bacterial infection. Then sometimes they come too late, because in farmer times, when they had a viral infection, we directly started with an antibiotic treatment, although it was a virus, because we knew that the antibiotic will help to resolve the problems. And that changed now, and I think we are also a little bit too loose maybe, but also the patients. And maybe there we have to change our attitude again.
And now, in this new context, how do you think CF centers should adapt their strategies to surveil the microbiology problems?
That's very important. That's a really big issue. So one thing is, when patients come to the visit, they're really stressed to get sputum, because usually it's not easy for them right now because they have less sputum. So then maybe we only do a swab. So one thing is, we give the patient a container at home so that they can produce in the morning, and when they come, we have already the sputum sample. Then we also have the possibility that they can send it to us with a specific tube where media is in there, so that it's safe and stable. It can be on the way like 1 week. That's important. And the other thing is that we also try to monitor them more at home. So most of the patients have now an FEV1 device at home, so that there's also the chance to see if there's a drop and they don't feel it, they can call us and we decide if they need an antibiotic treatment, for example.
Is there any role for PCR or biomarkers in this surveillance, do you think?
I think we need new biomarkers, definitely.
Because some people don't produce sputum at all.
Yeah, that's why. I think that's why we need new biomarkers, and not from the sputum. Some people say, exhaled, whatever biomarkers, but I think it's the blood, which is not easy, because the patient then needs to come to the clinic. But maybe artificial intelligence in the future will help, because I think maybe some symptoms, then maybe the FEV1, so several things might then influence where we would say, or the AI would say, now there's an exacerbation. But I think we need new biomarkers right now. If they have no sputum, it's really hard to define an exacerbation.
And do you think the is one of your expertise areas, the fungal infection, right? Do you think the therapy with highly effective CFTR modulators is influencing the fungal colonization?
Yeah, I think, the bacterial colonization is influenced, also the fungal colonization, but it's even harder to find fungi compared to bacteria. So if they have no sputum, usually with a swab, you won't find any fungus in the lungs. So there we always use serum, so other biomarkers, to detect an elevation of specific antibodies, for example, because that's really difficult. Yeah, that's really difficult. But we had our own study. For example, ABPA is staying the same the last 5 years everywhere in Europe, so there's no change. Yeah, although we find less aspergillus, for example, but I think they are still the same, maybe even more, because the bacteria are lower, maybe even more fungal colonizations. I think that's a really important topic.
And do you think in this era it would be more difficult to decide when to treat an aspergillus infection, for instance, or when to observe and see how it goes? Maybe
it's easier, because I think if you now find an aspergillus, I really would treat it. In former times, I would say at our clinic, between 20 and 30% were colonized with aspergillus. We said, don't worry. Let's see if it is an ABPA. We measure the IgE. Maybe it's also bronchitis. We measured the aspergillus IgG. But now I think if there's aspergillus always the only a bug we are finding, I think then we should be eager to treat it.
Okay. Because that's a problem that we have, right? With aspergillus.
It is.
And aspergillomas, I have patients with aspergillomas that I don't know really if I might be more aggressive or not.
Usually it's a very long treatment, not only 2 weeks, but maybe 3 or 4 or 5 months even.
Yes, it was. This one in particular was treated for more than a year, and
exactly.
The aspergilloma is there. But now I have to consider other options. being the co-author of the Standards of Care that were published in 2024, what evidence gaps do you still consider most critical, particularly for patients who don't have mutations that are eligible for the new modulators?
Yeah, I think there are two really important points. One is sure class 1 mutation where they can't receive modulators, but there are also patients who are not responding as well as other patients. So I think that's also a part of the patients that is usually missed because they say, yeah, they have modulator therapy, they will be fine. That's not the truth. And then we also had some patients who had kind of side effects with ETI, but now the change with Aliftraq, they are stable. So that's a positive sign, I think, with the new modulator therapy. So the next generation with Aliftraq, I think it's better. So it's better tolerated. So for this group, it might help. And still, sure, it's a class 1 mutation, I think, where we have to look at it. It's like the classical CF still.
Do you think Aliftraq as in the practice, in the real life, as a bit of a better profile of security, of less adverse?
Yeah. We are changing all the patients for Aliftraq, because it's once daily. That's really a bit better for us, we thought, but it's a huge amount of relaxing time for the patient because sometimes I forget to take the second tablet in the evening. It's also sometimes hard to eat fatty meals in the morning. And so mental health, we measured it, is much better with Aliftraq. Yeah, abdomen score, there's a change, a positive signal. So now in the real world setting, we see a lot of positive results. We just had an interim analysis of 85 patients who are on Aliftraq. Right now we have 160. And in those patients, we see that more than half are kind of responding to Aliftraq.
Because mental health is a concern.
It is a big concern. It's really an issue. We're talking about it every time we see them in the clinic. And I would say it's 1/3 to 50% who have more or less issues, and then also maybe kind of side effects with ETI. But now with Aliftraq, it seems to really be better.
Okay. And from your position on the ECF board, what do you consider the major priorities for the European CF community over the next 5 years?
Yeah, I think first thing is to get treatments to all countries. Yeah, so that all patients can receive modulator therapies. I mean, they have the right mutation, but maybe the country might not afford to pay the money, the health insurance in the country. I think that's really number one. And I think diagnostics is important, but it's not that important as a therapy with the next CFTR modulator therapy. And I think also we have to kind of support the CF centers, because I think in all the countries, usually pediatric clinicians are the number one doctor for CF. But for example, in Germany, we have 70% of adult patients and only 10% of adult physicians who are looking after patients. So I think that's the second issue, that we have to change that, because they will have more complications in the future. Patients are getting older, and there we really need to be prepared. And I think we are not prepared yet.
And you also think that we should try the new modulators in people with non-eligible mutations, just to try rare mutations that really weren't tested in the studies?
I think so, yeah. I mean, that's what we did before already. So we had a lot of off-label therapy and tried it, and it was then reimbursed by the health insurance, so we can apply for it in Germany. I mean, Pierre Regie did a lot of studies on that. So he said, we should try an all single patient. We did it. For example, we have one mutation, stop mutation, which is not responsive in his study, but in our study, she is responsive. So I think on an individual basis, we might try it in all cases, but you need to have the drug then and get it on the long run reimbursed. And I think everyone has to apply. It's a health insurance on a country level, but I think we should,
Okay. And to finalize, What message would you like to convey to CF centers in countries such as Portugal, where teams continue to strive for excellence, but they work within more limited healthcare resources?
Yeah, I think that's right now true for all the countries, not only for Portugal. We all suffer because of the system. I think in the future there might be less money for hospitals, for CF centers, not only in Portugal, but around the world, I would even say. And I think one big positive thing is that we are really in touch together in Europe. We are close to each other. We have a network, and we should really, maybe also on an EU level, try to get really support, financial support, but also mental support to treat the patients as we want to, because we have a lot of expertise. Then suddenly there's a stop because we might have not the money. So I think to have always guidelines, European guidelines who support our work, that's the first step, and that's what we are doing right now, also with the standard of care. This will support Portugal and all the other countries, and I think we try to keep on track and give the patients the best support and expertise and medical support they need.
Yeah, well, thank you very much for your time, for sharing with us your experience, your insights, and for your continued contribution to the cystic fibrosis community across Europe. And in fact, the cystic fibrosis community is a very good community. Yeah. It's very tight. It has been a pleasure to be with you again. Obrigada a todos por assistirem. Obrigada à SPP pela oportunidade e continuem a estar ligados ao podcast.